Hello students. Welcome to Concepts of Care for Patients with Stomach Conditions, Part 3. We're going to talk about gastric cancer right now, Part 3. Okay, so let's start with a video, okay, to present the disease. Okay, let's watch this video.
Today's topic is stomach cancer. Stomach cancer is the growth of cancerous cells within the lining of the stomach. Stomach cancer usually develops in the mucus-forming cells that line the stomach. This type is referred to as adenocarcinoma and accounts for around 90 to 95% of all stomach cancers. Also known as gastric cancer, stomach cancer is the 5th leading cause of cancer and the 3rd leading cause of cancer-related death across the globe. Stomach cancer is difficult to diagnose as it doesn't cause any early symptoms. By the time symptoms occur, cancer would have reached an advanced stage and may have metastasized. Metastasis occurs when cancer spreads to other parts of the body. Stomach cancer is prevalent in East Asia and Eastern Europe and occurs twice as often in males than in females. There are 4 stages of stomach cancer: stage 1, 2, 3, and 4. Cancer at stage 1 is limited to the top layer of tissue lining the inside of the stomach. At stage 2, cancer has spread deeper into the muscle layer of the stomach wall. At stage 3, cancer may have grown through all the stomach layers and spread to structures surrounding the stomach. Stage 4 indicates that cancer has metastasized. Causes. The stomach is an upper part of the digestive tract that is responsible for digestion and the movement of nutrients to the rest of the digestive organs, become cancerous and grow out of control, forming a tumor. There are some risk factors that may predispose an individual to develop these cancerous cells. This may include H. pylori bacterial infection, smoking, stomach polyps, a diet high in salty, pickled, or smoked food, a family history of stomach cancer, lymphoma, tumors in other parts of the digestive system, long-term stomach inflammation. Symptoms: fatigue, severe frequent heartburn, nausea and occasional vomiting, abdominal discomfort, which may worsen after meals, bloody stools, loss of appetite accompanied by weight loss, constant bloating, feeling full after eating a small amount of food, jaundice. Diagnosis and treatment. The doctor will ask about your medical history to see if you have any risk factors for stomach cancer and to know if you have a family member with the disease. To make a diagnosis, your doctor may carry out one or more of the following tests. Imaging test, which may include CT scan and a special type of X-ray called barium swallow. Endoscopy test, to visualize your stomach and look for signs of cancer. If any suspicious areas are found, a biopsy may be done. To check if your cancer has metastasized, exploratory surgery may be performed. Treatment. Your treatment will depend on the stage of your cancer, your preferences, and your overall health. Treatment may include surgery, therapy, and medication. The goal of surgery is to remove all of the cancerous cells in the body of the stomach and some health issues. Options may include removing early-stage tumors from the lining of the stomach, subtotal gastrectomy. For this, only the portion of the stomach affected is removed, total gastrectomy. For this, the entire stomach and some surrounding tissue are removed. Surgery to relieve signs and symptoms. Radiation therapy and chemotherapy may also be used. These procedures are both used to kill cancer cells. Radiation therapy uses a high-powered beam of energy, such as X-rays and protons, to kill cancer cells. Chemotherapy is a drug treatment that uses chemicals to kill cancer cells. Some targeted drugs are also used for treatment. These drugs may include trastuzumab, ramucirumab, imatinib. Targeted drugs may be used in combination with chemotherapy drugs. Supportive care, which is provided by a team of doctors, nurses, and other trained professionals, to help improve the quality of life for people with cancer and their families. Supportive care used with all of the appropriate treatment may help people with cancer feel better and live longer. Thank you for watching our video. Please do not forget to like and share the video. Also, please subscribe to the channel to stay updated on our latest videos.
Thank you so much. What a great video. Basically, this video reviewed the whole topic that I'm going to present. So we know that most cancers of the stomachs are adenocarcinoma. This type of cancer develops in the mucosal cells that form the innermost lining of any portion or all of the stomach. In adults, this happens in adults over 65 years of age. No symptom in the early stages, and the disease is advanced when diagnosed, when it's has already metastasized. Pathophysiology review: atrophic gastritis and intestinal metaplasia, abnormal tissue development are precancerous conditions. Inadequate acid secretion in patients with atrophic gastritis creates an alkaline environment that allows bacteria, especially H. pylori, to multiply. So when it says inadequate acid secretion, means that the stomach is not having the pH 1 that is normal, right, under the stomach environment. So this infection causes mucosa-associated lymphoid tissue, which starts in the stomach. Gastric cancers occurs in either the upper portion of the stomach, the cardia, or lower portion of the stomach, the non-cardia. Direct invasion of and adherence to adjacent organs like liver, pancreas, and transverse colon may also result, because the transverse colon is the one that is very close to the stomach, right? Hematogenous spread via the portal vein to the liver and via the systemic circulation to the lungs and bones is the most common mode of metastasis. Peritoneal, that's good to know. Please conduct corresponding assessment in those systems, in the respiratory, right? And also check the bones in your blood work, okay? Peritoneal seeding of cancer cells from the tumor areas to the omentum, peritoneum, ovary, and pelvic cul-de-sac can also occur. In adults with advanced gastric cancer, there is invasion of the muscularis, stomach muscle, or beyond. These lesions are not cured by surgical resection. The overall 5-year survival rate of adults with stomach cancer in the United States is around 30%, because most patients have no symptom until the disease advances. If detected early, the 5-year survival rate is closer to 70%. So it's important to detect and to report these signs and symptoms to the gastroenterology as soon as possible. Well, it all depends on the type of insurance, the patient education, right? Infection with H. pylori is the largest risk factor for gastric cancer because it carries the cytotoxin associated gene A. Patients with pernicious anemia, gastric polyps, chronic atrophic gastritis, and achlorhydria, which means absence of secretion of hydrochloric acid, right, are 2 to 3 times more likely to develop gastric cancer. Healthy equity: all non-white groups, especially blacks and Hispanic, have a higher incidence and mortality rate associated with non-cardiac gastric adenocarcinoma when compared with white groups. Korean and Japanese Americans have the highest incidence and mortality. Higher percentage of non-white groups who smoke and have H. pylori that is not treated due to the possible lack of healthcare access, poverty, and lack of guidelines for gastric cancer screening. Okay. Now, white groups are more likely than non-white to have chemotherapy prior to surgery for cancerous lesion, possibly due to lack of healthcare access of healthcare insurance. So they are treated that way instead of having the surgery. So the disease also seems to be positively correlated with eating excessive pickled foods, okay? Nitrates from processed foods, your hot dogs, your sausages, and salt added to food. The ingestion of these foods over a long period can lead to atrophic gastritis, a precancerous condition. A low intake of fruits and vegetables is also a risk factor for cancer. Please read this paragraph and be aware of this. Gastric surgery is also linked to an increased risk for gastric cancer because of the possible development of atrophic gastritis, which result in changes to the mucosa. Gastric surgery, which includes your bariatric surgery, okay? Patients with Barrett's esophagus from prolonged or severe gastroesophageal reflux disease have an increased risk for cancer in the cardia at the point where the stomach connects to the esophagus. So you get your bypass bariatric surgery, right? To find a solution for your obesity, right? But in the other hand, you are getting risk for getting gastric cancer, when in fact it's easier and healthier to lose weight following appropriate diet and exercising, right? So, and I'm very worried about all these surgeries that are being done right now, especially in the young population in the United States, right? Okay, assessment. Although patients with early gastric cancer may be asymptomatic, dyspepsia and abdominal discomfort are the most common symptoms. Okay. In patients with advanced disease, anemia is evidenced by low hematocrit and hemoglobin values. Patients may have microcytic or macro or microanemia, microcytic anemia, associated with diseased iron or vitamin B12 absorption. Let's stop here. Macrocytic is your B12 and folic acid. Okay, microcytic is your iron deficiency anemia. The stool may be positive for occult hypoalbuminemia, and abnormal results of liver tests, bilirubin and alkaline phosphatase occur with advanced disease and hepatic metastasis. Yes, the level of carcinoembryonic antigen, your CA, is elevated in advanced cancer of the stomach. The primary healthcare provider uses esophagogastroduodenoscopy with biopsy for definite diagnosis of gastric cancer. Biopsy of all visible lesions can be performed to determine the presence of cancer cells, and also other tests are going to be performed. CT, your PET scan, and MRI of the chest, abdomen, and pelvis are used in determining the extent of the disease and in planning therapy. So here you have a table, very interesting, key features of early versus advanced gastric cancer. In the early presentation, you're going to have chronic dyspepsia, abdominal discomfort, feeling of fullness, epigastric, back or retrosternal pain. But in advanced cancer, you're going to see your iron deficiency anemia, nausea, vomiting, enlarged lymph nodes, and progressive weight loss, right? Non-surgical management, radiation and chemotherapy could be used. Combination chemotherapy with multiple cycles of drugs such as oxaliplatin, fluorouracil, cisplatin, and epirubicin before and after surgery may be given. But bone marrow suppression, nausea, and vomiting are common adverse drug effects. Common adverse drug. Bone marrow suppression. This is it's very bad. Radiation, the use of this treatment is limited because the disease is often widely spread to another abdominal organs at diagnosis. So organs such as liver, kidneys, and spinal cord can endure only a limited amount of radiation. That's why radiation is limited and at some point is controversial. Surgical management. The primary surgical procedure for the treatment of gastric cancers are total and subtotal partial gastrectomy, as we saw in the video. In early stages, laparoscopic surgery, which is the minimally invasive surgery, plus adjuvant chemotherapy or radiation may be curative. Those are in early stages, right? For most patients with advanced disease, are candidate for palliative surgical treatment. Metastasis in the supraclavicular lymph nodes, inguinal lymph nodes, liver, umbilicus, or perirectal wall indicates that the opportunity for cure by resection has been lost. Palliative resection may significantly improve the quality of life for a patient with obstruction, hemorrhage, of pain. This condition is very sad, and as the video explained and the book is explaining, it's difficult to diagnose in early stages, right? And when the disease is given symptoms is when it's already metastasized. Perioperative care before conventional open approach surgery and nasogastric tube is often inserted and connected to suction to remove secretions and empty the stomach. So patients having laparoscopic surgery, which is another approach, minimally invasive, do not require an NG tube. Because weight loss is problematic for patients with gastric cancer, nutrition therapy is a vital aspect of preoperative and postoperative management. Before surgery, compression by the tumor can prevent adequate nutritional intake. To correct malnutrition before surgery, if present, the primary healthcare provider may prescribe enteral supplements to the diet and/or total parental nutrition, like vitamin, mineral, iron, and protein supplements are essential to correct nutritional deficits. That's very important. Operative procedure. In the case of total gastrectomy, the surgeon sutures the esophagus to the duodenum or jejunum to reestablish continuity of the GI tract. But I've seen this. It's very traumatic, very traumatic. You need a psychology to teach the patient to understand the amount of food that needs to be eaten and how it has to be eaten, right? The intake. So, because remember, you don't have the same space. The stomach is elastic and can expand. But when the esophagus is connected directly to the jejunum, the canal is very narrow. So there is a limited amount of food and you have to eat in different ways that you used to. The surgeon, okay, for patients with advanced disease, total gastrectomy is performed when gastric bleeding or obstruction is present, or when most lymph nodes around the area are compromised. Sometimes they remove the whole stomach because the lymph nodes are compromised. Okay, postoperative care. Provide postoperative care for patients who have had general anesthesia to prevent atelectasis, paralytic ileus, wound infection, and peritonitis. Auscultate the lungs, take vital signs as appropriate to detect signs of infection or bleeding, and that's good to know. Aggressive pulmonary exercises and early ambulation can help prevent respiratory complications. And DVT, inspect the operative sites every 8 to 12 hours for the presence of redness, hyperpigmentation, swelling, or drainage, which indicate wound infection. Keep the head of the bed elevated to prevent aspiration from reflux. That's good to know. Again, so now we are going to watch a video about dumping syndrome. It's dumping syndrome. It's not dumpling, okay? Dumping syndrome.
Dumping syndrome is a very common complication following gastric and esophageal surgeries. Also known as rapid gastric emptying, dumping syndrome is a condition in which undigested food moves too quickly from the stomach to the small intestine. In other words, food gets dumped into the intestine before being properly digested. This happens because the valve that separates the stomach and the small intestine, called the pyloric sphincter, was either removed or damaged in the surgery. There are two forms of the disease, based on when symptoms occur, early or late. Early dumping happens between 10 to 30 minutes after a meal. Symptoms arise as the rapid dumping of the undigested, concentrated food mass triggers the body to move fluid from the bloodstream into the intestine in an attempt to dilute the food. The resulting distended intestine produces bloated feelings, abdominal cramps, nausea, vomiting, and diarrhea. This shift of fluid, when excessive, may also significantly reduce blood volume, causing rapid heart rates, dizziness, lightheadedness, or even fainting. Late dumping symptoms occur within 1 to 3 hours after eating. At this point, the rapid increase in sugar absorption triggers the pancreas to produce more insulin in an attempt to prevent too high levels of blood glucose. However, it may overreact and produce too much insulin, causing instead too low blood glucose levels or hypoglycemia, which may manifest as weakness, sweating, confusion, and tremors. Increase in gastrointestinal hormones is also observed and thought to contribute to both early and late symptoms. Symptoms are often more severe after meals that are high in simple carbohydrates, such as table sugar. Most cases of dumping syndrome can be successfully managed with diet changes. These include eating smaller meals throughout the day, avoiding foods with high simple sugar content, choosing foods that are rich in proteins, fibers, and complex carbohydrates, delaying liquid intake until at least 30 minutes after a meal, adding thickening agents to increase food consistency. If these fail, medications that slow down gastric emptying or inhibit insulin release may be prescribed. Tube feeding that bypasses the upper digestive tract or corrective surgery such as reconstruction of the pyloric sphincter may be performed as a last resort.
Thank you very much. So there you go, dumping syndrome. This syndrome is believed to occur as a result of the rapid emptying of food contents into the small intestine, which shifts fluid into the gut, causing abdominal distension, right? Observe for early manifestation of this syndrome, which typically occur within 20 minutes of eating. Symptoms include vertigo, tachycardia, syncope, sweating, pallor, ash-gray skin, palpitations, and the desire to lie down. Late dumping syndrome, which occurs 1 to 3 hours after eating, is caused by a release of an excessive amount of insulin. Is caused by a relief of an excessive amount of insulin. The insulin release follows a rapid rise in the blood glucose level that results from the rapid entry of high carbohydrate food into the jejunum. What important is this sentence? Very important. The insulin release follows a rapid rise in the blood glucose level that results from the rapid entry of high carbohydrate food into the jejunum. Observed for manifestations including dizziness, lightheadedness, palpitation, diaphoresis, and confusion. Dumping syndrome is managed by nutrition changes that include decreasing the amount of food taken at one time and eliminating fluids ingested with meals. Also, we need to teach the patient to eat a high protein, high fat, low to moderate carbohydrate diet. Acarbose may be used to decrease carbohydrate absorption. A somatostatin analog, octreotide, 2 or 4 times daily, 30 minutes before meals may be prescribed in severe cases. This drug decreases gastric and intestinal hormone secretion and slows stomach and intestinal transit time. What important is to understand your drugs, your mechanism of action. Delayed gastric emptying is often present after gastric surgery and usually resolved within 1 week. Edema at the anastomosis or adhesions. Obstructing the distal loop may cause mechanical blockage. Metabolic causes like hypokalemia, hypoproteinemia, or hyponatremia, right, should be considered. Hypokalemia is low potassium. Hypoproteinemia means low levels of proteins, and hyponatremia, low sodium. Several problems related to nutrition develop related to partial removal of the stomach, including deficiencies of B12, folic acid, and iron. Yes, because we need hydrochloric acid, and if they partially remove parts of the stomach, probably they are going to remove the parietal cells, we are going to secrete hydrochloric acid, therefore iron is going to not be absorbed. Okay, it's going to cause a lack of absorption of iron. Impaired calcium metabolism and reduced absorption of calcium and vitamin D. These problems are caused by a reduction of intrinsic factor. So assess for the development of atrophic glossitis secondary to vitamin B12 deficiency. In atrophic glossitis, and this is very important when you assess the oral cavity of a patient. In atrophic glossitis, the tongue takes on a shiny, smooth, and beefy appearance. The patient may also have signs of anemia secondary to folic acid and iron deficiency. Monitor the complete blood count CBC for signs of megaloblastic anemia, low red blood cells, RBC level, and leukopenia, low white blood cells, WBC level. These manifestations are corrected by the administration of vitamin B12. Okay. Care coordination and transition management. Patients who have undergone total gastrectomy and those who are debilitated with advanced gastric cancer are discharged to home with maximal assistance because it's really sad. Total gastrectomy, maximal assistance. Patients who have undergone subtotal gastrectomy and are not debilitated may be discharged to home with partial assistance for ADLs. Recurrence of cancer is common. These patients with total gastrectomy, they are faint very frequently. I'm telling you. Because the nutrition is going to be totally different. The amount of food they are going to have is going to change. I have seen a couple of patients going through total gastrectomy, and for almost 2 years, one of them, he had very frequent fainting episodes. We need to take the patient to the hospital very often. So we have a problem there with electrolytes, protein, malnutrition in general. It's not easy. Home care management. Gastric cancer is a life-threatening illness. Consequently, the patient and family members require physical and emotional care. Yes. Self-management education, educate the patient and family about any continuing needs, drug therapy and nutritional therapy. If patients are discharged to home with surgical dressing, teach the patient and family how to change the dressing. Review the manifestations of incisional infections, fever, redness, hyperpigmentation, and drainage that they should report to the surgeon. Patients who will be receiving radiation therapy or chemotherapy require instructions related to the side effects of these treatments. Nausea and vomiting are common side effects of chemotherapy. So there you go. You have, besides the lack of proper nutrition, you are having more risk for fluid and electrolytes imbalance due to the nausea and vomiting, and instruction in the use of prescribed antiemetics may be needed. Teach the patient and family about the type and quantity of food that will provide optimal nutritional value. Interventions to minimize dumping syndrome and decrease gastric stimulants are also emphasized. Remind the patient to eat small, frequent meals, and that's one of the facts that patients they don't understand. It's difficult for them to get into the habit to get a small, especially they got total gastrectomy. Avoid drinking liquids with meals because it's going to promote dumping syndrome. Avoid food that cause discomfort. That's another difficult to understand fact. Eliminate caffeine and alcohol consumption. Begin a smoking cessation program if needed. Receive B12 injections as prescribed. Lie flat for a short time after eating. NCLEX questions. Which client statement regarding diet and nutrition after a total gastrectomy requires further teaching by the nurse? I should stay sitting up for an hour after I eat? No, that will cause dumping syndrome. I will avoid liquids with my meal. That's a good fact. I need to eat small, frequent meals. Yes, I need to stay away from concentrated sweets. That's the sugars, right? So let's review the mastery questions. The nurse is reviewing the laboratory test result for a client recently diagnosed with peptic ulcers, which result with the nurse report immediately to the healthcare provider, to the PCP. Are we going to report blood urea nitrogen of 16 mg? Are we going to report serum creatinine 0.9? Are we going to report hematocrit 33%? Wow, that's low. Serum glucose 102, that's normal, right? So we're going to report the hematocrit. Which of the following statements to promote gastric health would the nurse include to educate an adult client? Select all that apply. And all these are good choices. Stop smoking or using tobacco. Do not drink excessive amount of alcohol. I actually believe that we have to avoid alcohol at all. Consume a healthy, well-balanced diet, exercise on a regular basis, avoid excessive amount of pickle or smoked food, avoid taking large amount of NSAIDs. So with this, we have concluded chapter Concepts of Care for Patients with Stomach Conditions. We just finished the gastric cancer. Thank you for your attention. And when we come back, we will be discussing more gastrointestinal disorders in future chapters. Thank you.